Okay, and I'm going to, as everybody is joining in on the panel, I also want to introduce one of our panelists because the other panelists I've already introduced today. And I want to introduce Dr. Yuanpo Tu, who is based at in the Pacific Northwest and has been at the Everett Clinic for a number of years and served in a variety of capacities. And he is actively involved in leading their efforts in terms of clinical research for COVID-19 patients, studying a variety of very interesting areas like different types of collection sites, self-collection. And so we have the privilege of having Dr. Tu join us along with our other panelists today, which are Dr. Heichman, Dr. Rogers, Dr. Kruger, Dr. O'Leary, and Dr. Tu. So welcome to all of you. And we've had a number of questions come in today. And what I'd like to do is have this, we have about 30 minutes and have sort of some different sort of additional perspectives brought in today. I want to continue first on with some of the ideas and themes that Dr. Heichman talked about. Perhaps I will ask you, Dr. Heichman, because you just gave the presentation and then commentary from others, this model that's used in the agricultural world for high throughput testing of infectious pathogens in meat inspection, et cetera. I mean, it's a very interesting concept to think about at sort of a national level within the United States, and it could be applied in other countries as well. How would you envision this actually being, sort of financially done? How would it be funded, essentially, given our sort of multiple states and that? What is your vision or from your perspective?
Right. So that's a really good question. And I think it really speaks to some of the general challenges around healthcare in the United States, where in some ways it's really federated and distributed to the states. And in other ways, you might think about it as a national issue, right? And certainly the disease knows no boundaries across the states. I would imagine that like we administer vaccine programs and other more centralized programs, maybe, I know the newborn screening is done by the states, but right. Sort of the national mandates, I think, might be able to be tapped into this, especially in the setting of very low cost testing. It might be something that there could be a national program for that would be inexpensive and coordination could happen. My hope would be that it would be taken on at a federal level. I almost think that by enabling the molecular pathologists, maybe through AMP or something, that there could be, involvement of the professional societies that could help put forward some of the ideas around this and champion the idea of more of a national network for testing in this manner. Great,
thank you. I want to ask a next question that I'm hoping that both Dr. Rogers and Dr. Tu could give their perspectives in terms of being panel members who are actively seeing and treating patients with COVID-19. Although it's summer, very quickly we will approach the autumn and winter of the 2020-2021 seasonal influenza, the return, and also of respiratory symptoms being presented due to a variety of pathogens, both from pediatric settings to adult settings. So my question is, what is your sense of how you're going to approach this in terms of the differential diagnosis and the diagnostic workup of these individuals, particularly, say, if they have COVID-19, but they're not presenting yet in sort of classic symptomatology with changes on the CT scan, et cetera. I'd really like to hear your perspective about how you're thinking about that in your own institutions and how you're preparing for that. So either Dr. Tu or Dr. Rogers, I want to hear both of your perspectives. So Dr. Tu, you're joining us as a first time for today, so let's hear your perspective first.
So thank you for inviting me to the panel. The first thing that we're thinking about right now is how to vaccinate people for influenza. So if you think about the vaccination campaign for influenza, it should not occur in July and August. It's in the Northern Hemisphere, should start somewhere in late September and October. And we don't want 60,000 people trooping through our clinic. And so the whole issue is how do we set up outpatient, high throughput vaccinations for influenza? And as an extension of that, how are you going to do the same thing with a potential new COVID vaccine? And so we're in discussions with FEMA and others to look at drive-through tent testing, similar to what we have for drive-through testing of COVID, drive-through vaccination. The second issue is that what viruses versus bacterial pathogens can you treat for community-acquired pneumonia or lower respiratory symptoms? Obviously, we have treatments for influenza, and COVID is important to identify just because it has potential for higher morbidity and mortality. And then there's RSV in the younger populations. And so I think those are the three target viruses that we want to be focusing on. There are fairly fast point of care testing now available for both COVID as well as influenza, but they are basically would have to be run on two different parallel machines at the same time. And the turnaround times on those is generally less than an hour. We use those extensively in our current practice in the outpatient setting. RSV can also be identified, but that's really targeted to kids underneath the age of 1 and in the immunocompromised adults. So those are the three viruses that we're thinking about how to target. There's obviously some development of platforms which would target both influenza and SARS-CoV-2 at the same sample at the same time.
Great, thank you. Dr. Rogers, could you comment on what you're thinking about in your own institution?
I would re-emphasize two of those main points, which is first, prevent anything we can prevent. And then the idea of multiplex panel, I think, is going to be very, very useful just for efficiency more than anything. I think despite those two things, we're still going to have a lot of folks presenting either outpatient or inpatient with an undifferentiated, presumably viral upper respiratory or lower respiratory illness. And, given some of the limitations on the diagnostics that we all know about that we discussed today with the clinical sensitivity, we're going to be stuck in a situation where we don't really know what's going on. I'm hopeful that between now and then, beyond working on some more therapeutics and some more safety signals for those therapeutics that we might feel more useful giving them less judiciously, that we're going to gather some more information on other kind of clinical signs, symptoms that can point us one way or the other. We are getting pretty comfortable even without PCR, seeing the strong lymphopenia, seeing the strong, elevated high B dimer, things like that we can more formally put together in a risk calculator. I think we're going to be able to help find some adjunctive diagnostics which will help us out. But I think the main two things that Dr. Tu brought up are going to be the most important: preventing things we can prevent, kind of checking for everything.
Great, thank you. Another question that I'd like to ask the group is, and I'm not certain I can see, is Dr. Kruger. Dr. Kruger, are you with us currently?
Yep, I'm here.
Great, thank you again for joining us. There's been a tremendous, earlier in the day you alluded to it and others have alluded to it, the issue of supply chain to support the testing efforts, both in your own institution and nationwide. Can you comment on sort of the current bottlenecks of supply chain in terms of reagents or other aspects of the testing that you might be experiencing?
Yeah, and I think I did allude to this a little bit in that discussion. And again, I would reiterate, if you can think of a product, piece of lab equipment, or plastic that is used in RT-PCR testing, it's limiting. So, I mean, we have validated at least 3 of everything that we use in the lab for RT-PCR testing, from one-step RT enzymes, all the way down to tips that go onto the Hamilton. PCR plates are limiting, deep well plates for extraction are limiting. I think what we had been dealing with for a very long time was that, just the collection devices themselves were limiting. And that was, again, a big push within LabCorp to try to get something validated to actually be able to do the testing. I mean, we had the capacity, but the community didn't have the swabs. And I early on in the pandemic, we had something like 4 or 5 million swabs in the warehouse, and they were all ordered within 3 days. So right there, our supply was immediately depleted. So you think people are just hoarding toilet paper at Harris Teeter or the local grocery store, but we saw that even with the collection swabs within the community. So along with the home collection kit, that was a big part of that, was finding an alternative swab, finding an alternative transport media, and finding an alternative transport media that worked without having a significant cold chain.
One of the, I'd like to circle back to Dr. O'Leary, who was our first presenter this morning, and kind of, Dr. O'Leary, I'd like to kind of ask your impression on some of the data that's been presented today in terms of your sense of maybe kind of revisiting where you think some of the gaps in our knowledge is in terms of sort of the current status of diagnostic testing that you weren't able to necessarily present on this morning as in terms of your overall presentation.
First of all, I think the presentations were all very good, and I think they addressed a lot of the challenges. I think Dr. Hilliard pointed out the issues associated with the analytical characterization of tests, and I think that's really important because it just takes way too many cases to get high precision on the clinical validation of these tests or comparisons. I mean, nobody is going to be doing 10,000 tests to compare one swab versus another, especially when neither one of them is available all the time. You just want to make sure that you're good enough. I think that maybe there's a challenge in training associated with certain procedures. Getting a good nasopharyngeal swab is not necessarily something that everybody learns in medical school and is able to attain afterwards. And I would suspect that the vast majority of physicians, and maybe the vast majority of physicians that are doing NP swabs, actually don't necessarily have the expertise that you would like. This may color a little bit of some of the pre-analytical issues. I think that understanding how all of this fits into the public health system, and particularly the epidemiology of transmission and how we attack who we sample in order to optimize public health decisions, such as decisions to close down or limit meeting size, may be very, very important. There may be choke points in the transmission of this disease. We already know about some of them, nursing home staff, for example, that are very important. Well, it may be that it's more important to test routinely people that are commuting on a commuter train than it is people that are going into an office. And I think getting some better collaboration with what's going on with the epidemiology and public health people, not leaving it as a straight medical decision, but as a medical plus public health decision on how to optimize testing is a really important step forward.
You know, I'd like to also invite the other panelists to, when any particular panelist kind of makes a commentary on a question, if you have some follow-up thoughts on that from your own perspectives or institutions, please go ahead and sort of unmute yourself and speak up. I would just comment that one of the points that I'm not certain we were able to really address today for our audience was to get a better idea of sort of the role of, we heard from Dr. St. George about the efforts through the Wadsworth Center, the Public Health Center in New York, but it would be interesting to have a broader perspective of the role of the public health laboratories, the diagnostic testing that they're doing, say, versus individual hospital laboratories versus commercial reference laboratories. I would like to have a better understanding of what proportion or percentage of testing being performed for SARS-CoV-2, for molecular testing, for example, let's say, is actually being performed in public health laboratories versus, if you will, in university hospital settings and private commercial laboratory settings. And anyone on the panel who might be able to provide a perspective on that, that would be really nice for our audience. Looks like Dr. Chu might have some perspective on this.
So this is Poe from Everett, and we're about 25 miles north of Seattle, and it's home to the University of Washington, and the state lab is located between our clinic and downtown Seattle. The Everett Clinic had the good fortune of having the first community-acquired patient, 17-year-old, and was also the site, the Everett area was the site of the first person hospitalized in the United States. And really the first wave hit the Seattle area very, very early in the epidemic. Initially in the last weeks in February and the first 2 weeks in March, all the testing was essentially being performed at the university, at the public health lab. It was only until about the 10th of March that the University of Washington brought on their initial EUA, CDC EUA SARS-CoV-2 testing. And that was actually the first lab that I had contacted in performing my trial that has been referenced by Dr. Heichman and Tim O'Leary. And what was really interesting was having an agreement for them to run the samples in that trial on Thursday. By Saturday, they were overrun and their capacity was overloaded. And that's actually how we ended up contacting through Karen Heichman and the Gates Foundation and Quest, where the Quest ended up running those samples. Quest, during our trial, became overrun by samples as well. And they were running their Roche machine so hard at the end of the trial, it was literally breaking down every other sample run. And so the information presented on AMP showing that we are running multiple platforms and multiple labs, and the smaller your lab is, the more likely you're going to have multiple platforms. It's just a reflection of the changing dynamics of testing over time. But public health was really important early on because they had the only testing available.
Great, thank you. Dr. Rogers, could you comment on, within your own institution, is it your medical school department of pathology or laboratory medicine? Is that who is providing all the testing for the patients, at least in your own hospital setting?
Yeah, I would echo, it's been a very dynamic situation. Clearly just public health laboratories had access at the beginning. and then it kind of spread from there, as we mentioned earlier, as commercial labs upkeeping and many university labs across the country, each are kind of developing their own capacity. I think it's the key point that, the goal is an efficient use of tests, right? So when you need a rapid test, doing it locally, when you need high throughput, doing it at a high throughput lab, I don't think we're there as a country. We have those three kind of big arms that we've discussed, and each area of the country is different. So in particular, in our area, we're a pretty darn small state, and we are, have a public health lab, and we're also the largest institution in our state. So in our particular instance, it transitioned pretty nicely from public health lab to, as our numbers ramped up, to a very strong clinical micro department here. We're able to get access to multiple different platforms. We've actually been kind of a default for the overflow in the state. So things, rather than flowing from us to the public health, they're flowing from public health to us because we have the capacity to do so. Similarly, there was some thought earlier on sending out to commercial labs, and a lot of, as was mentioned earlier on, the clinical labs were pretty overwhelmed. There's backlogs just because everybody wanted the test to be done. So in particular here in our instance, our lab at our institution has been key to providing throughput, not just for hospitalized and outpatient folks, but for pretty much the whole state. But clearly that's not the case in other instances around the country. And hopefully each one's kind of found their own way to do it. But I think it would be wonderful if we could have a coordinated effort to do this efficiently and the right test to the right people. I just don't know the mechanisms of doing so.
Great, thank you. Dr. Kruger, I'm going to make an assumption that you had the opportunity to hear Dr. Heichmann's presentation. And in that context, earlier today, you presented on the at-home collection initiative that LabCorp is involved in. And I'm kind of interested in understanding in terms of how that's been implemented and say your perspective on what Dr. Heichmann presented and where there might be similarities or some divergences in almost sort of execution and implementation that you could see in terms of your own experience. Thank you.
Yeah, no, I think Karen's presentation was really great. I love seeing things like that because that's what we do every day. I mean, we have systems in place that process millions of blood tubes a day. Oh, sorry about that. I think the biggest issue, again, is going to be the logistics. So I think it's always really challenging when we hear about, a single site processing 3 million samples. I just think to myself, how are those envelopes going to get opened? How are those tubes going to make it into a rack? How are those swabs going to get out of those tubes and make it into a plate? And those are certainly things that, we're really good at doing, and I think the industry itself is really good at doing, especially if we have the year and a half lead time to build those types of very high throughput automation systems. I think it's challenging to imagine how those things are going to be built on timescales that are relevant to this pandemic. I think certainly it's really awesome to think about those things for future pandemics, but I think it's really challenging for me to see how, even a Quest or, an ARUP or us would build one of those systems to be able to support that in anything less than a year. And, we have an internal robotics company called Protodyne that, this is what they eat, sleep, and bleed. I mean, this is what they do every day. They build out these very, very high throughput blood tube processing systems that spin, 1 million tubes a day through Roche analyzers. So I think it's certainly something we can do. I just wonder on what time scale.
Yeah, and maybe I could jump in here. So we definitely have some efforts underway through grantees and their partners and just other colleagues in the field that are looking at this issue right now. And I'm sure you can imagine a few different bottlenecks. One is, accessioning the tubes. And I know that your ARUPs and your LabCorps and your Quests have that, you know, worked out mostly with bespoke systems, right? Not generally extensible. The ag bio folks have a lot of that worked out too, but the sample preparation is a piece that I think is still a bottleneck, especially if you're coming from a dry swab. So you need to elute, and then either you need to extract the sample, or better yet, if you can go right into amplification of your targets, then you might be able to skip that extraction step, which is rate limiting, I think, in a lot of settings. And so definitely there are efforts underway to see if it's possible to go directly to PCR. And indeed, the early studies are indicating that might really be possible. And so I think that would be one step to overcome that barrier. I will say, though, that the ag bio companies have been working on this forever, and the companies that we've been talking to, you know, they have to extract nucleic acid from seeds and stems and leaves, and these are really hard specimens to work with. And so they have some very good ideas about how to make that transition from a tube to nucleic acid and ultra high throughput molecular testing. So I hope that by bringing together a lot of smart people, we'll be able to come up with a solution. And then the idea is to make that solution broadly available to everyone. So referenceable, you know, presented at meetings and published and really available to everyone. And that's the goal of the work that we're doing right now.
Maybe I can speak. You know, the eastern shore of Maryland is the home to many, many, many millions of chickens, and that are used to feed people across the United States. Every chicken house gets sampled very regularly, at least once a week. Now, they don't sample individual chickens and try to keep track of specimens chicken by chicken. They have to do it house by house, but they do this for avian influenza. They do it because once a chicken house becomes infected, they need to destroy the flock. So this is a tens of thousands of dollars worth of decision making that goes on a regular basis, goes on to one of these large organizations that does look at millions of specimens a year. So there are some differences having to do with specimen labeling, but the throughput issues have been thought through on the agriculture side, and it's just amazing to watch what happens with chicken management.
Yeah. Well, I'm gonna, we only have a couple minutes left, and I'm gonna try to choose a question or two that have come in from our audience. This might be a question that perhaps Dr. Kruger could best address, given the position of his daily work. The question is, what is the rate of liquid leaking from transport tubes in your experience? Shall we say leakage or broken sample collection tubes that have come in your environment?
I don't personally keep track of those numbers. I could certainly field that question to operations. I know the QNS rate or the not run rate for those types of samples is quite low. So I don't think we necessarily see a whole lot of that, and I think that's most likely because most of the samples that we're getting are collected in physician offices, and they're put in, you know, coolers and cases where they're not getting crushed and jostled around and shaken. Trying to think if I have seen any recent data from the at-home collection, but it's similar there. I mean, it's a strong cardboard box that those samples are sent back in. So unless they're stomped on or rolled over by the FedEx truck, they're not going to get broken either. But I certainly can follow up internally about those numbers.
Yeah. Maybe I want to just follow up on a question or a comment that Dr. Tu raised earlier, and perhaps I'm going to direct this to Dr. Rogers as kind of a final question. This issue of how to address the upcoming autumn and winter in terms of vaccination. I was very intrigued by the commentary that Dr. Tu said about thinking through how this is going to be done. In your own healthcare system, Dr. Rogers, in your clinics, is this a point of active discussion in terms of how that's going to be implemented? Because we currently have people getting vaccines at doctors' offices. We have them being vaccinated in employee health clinics. They're being vaccinated at pharmacies for the flu vaccine. What is your perspective? And this is really in terms of how your institution or state is thinking about rolling out vaccination for influenza.
I don't know that there's been any specific thought at our institution or public health. There may be more in public health I'm not aware of for influenza or vaccination in particular, as our prevalence is, local prevalence has gone way down. I think having access to vaccination through all those routes that you mentioned is going to be important, and having not just one bottleneck where people get caught up. I think what has been given some more thought in is how would we, independent of the flu, if we have a new vaccine that needs to be rolled out for COVID, ideally, but who knows if that will happen this fall, what would be the mechanisms of doing so? And so I think it would be very easy to translate some of the preparation that's going into that, I think appropriately translate it into also, hey, how can we get everybody vaccinated for flu? So I think that's an opportunity that we have for improvement here. I wanted to tag on, not to take too much time, but to the earlier question about efficiencies of testing. I think, figuring out where to do the high throughput testing is a very important thing to do. But the other thing to remember is the kind of opportunity cost when the testing is done elsewhere. So I think, as we heard from New York State labs earlier, clinical labs as well, there's untowards amount of resources that are being devoted to testing in these places that's necessarily taking manpower, equipment away from other testing. So I think that's something to keep in mind as well. We're currently able to do this testing, but is it really the right place where that testing should be done?
Great. In terms of sort of wrapping up our panel today, are there any other points or comments that any of the panelists would like to bring forward that on topics either discussed or points that you feel we have not brought forward, important points that would be of benefit for the audience's knowledge today?
I think I would just like to add that as we're looking towards the fall and upper respiratory virus season and influenza and all of that, thinking again about what we've heard about the strategy around that and the possibility of multiplex tests, a common specimen for the tests, not having to run multiple different tests, but at the same time, I think being really clever about that. Certainly there are diagnostic developers that are thinking about that now, but from an algorithmic standpoint, what does that mean in the laboratory setting? What does that mean in the clinical setting? And really trying to think it through. Also using more disease priors or prevalence information to guide the testing. Certainly, you don't need to do RSV testing in a 40-year-old, but it might be important in, a less than 1-year-old. And so I think thinking through these things now and deciding how to best utilize the instruments and the reagents and the capacity in advance is going to be really important, just as much as sending kids back to school.
Great. Thank you. Well, I thank you, Dr. Heichman, and I want to thank all of our panelists today for your participation on the panel and for your earlier presentations. Just an outstanding day for myself. I'm going to turn the podium back over to Dr. Emily Lee to kind of guide us in next steps for the afternoon.